So I know we learned kinetic chain as a thing, but sometimes it will manage to skip an area. So she was saying that from the right hip to the left foot, there's issues, and just every now and again, related to kinetic chain, it doesn't always follow the pattern perfectly. But starting there and then seeing how unique the person is helps. I, for example, tend to be like all right side dominant, you know, so. Now, with hips, related to the deep lateral hip rotators, this is where we can get all that assessment. Now, one thing I showed was, you know, just rocking and rolling. The pelvis related to the low back. Now, this is right here the best way to do the rhythmic oscillation for the lumbar spine. You have to think about what those vertebrae are doing there as I'm doing this. Right? There's a little shimmy. But that's the best rhythmic joint movement I really have for you for the low back, as opposed to like in sideline, taking somebody and doing a bunch of stretches and stuff. This is sometimes the better tactic. Just rock it back and forth, rhythmic oscillation, rhythmic joint movement, and what that will do related to keeping those joints lubricated and pliable. And then if I'm going to pick a side to work on, the less symptomatic or the asymptomatic side, and then I can compare that to the symptomatic side, and that will be my assessment.
The oscillating just also helps with the muscles too if they're really tight and tense, right?
The rhythmic oscillation, yes, absolutely. Neurologically, rhythmic oscillation, like rocking a baby. Okay, think about it very much. There's something about this rhythmic movement that naturally correlates with reduced tone. So yeah, everything right here. Make sure that doesn't hurt the ankle.
Nope.
It's an actual normal size foot. It doesn't hook into my elbow as good as it usually would. But this works pretty good. Usually I stay more like this, so I'm doing this action. But that is rhythmic oscillation at the hip, the ankle, and if I just move back and forth like this, the knee as well. And then I want that tissue really moving, because then I also can get the muscle tone reduction, the slip and slide for connective tissue, and then also all of that is lymph drain, coupled with the oscillation is causing the change in shape of the tissue, thus those ducts and vessels are getting open and closed. So right here, this may in many cases be a more valuable lymphatic drain tool than the moving of the skin manually. If I have a big shortcut, is I would rather just do massage with tons of rhythmic joint movement and put kinesio tape on people. That would be my version of a more efficient lymphatic drain that I actually think works better. And the KT taping for a lymph drain is the simplest thing there is. You just have to cut the tiny strips and create what I call the quadrupus. It's just like the one with the tentacles. It'd take too long to make an octopus. That'd be some tiny tentacles.
I do have a question. With somebody that's laying prone, yes, thank you.
Prone now, yeah. This prone.
It's over here with the allergy assist.
I don't know why I'm thinking it's supine, because I'm thinking, oh, the face is down.
It's just morning brain.
Don't confuse me.
I know, I'm sorry. Anyways,
Prone.
and you have someone that's laying like that, and they're having a real bad amount of tightness in their back, especially their lower back. Would it be wise to kind of like, move it around and stuff like that, but would it be wise to start on the legs first and then come to the back? Like,
That's where you could make The challenge will be there's tons of good logical arguments like that. At the very least, maybe the hips. At the very
It's
least,
like
the
when you're
pelvis.
shaking the
Yep.
leg and stuff, like that's helping loosen
Oh
some
yeah,
of the back
maybe
muscles
not the
and hip
massage stuff, but
muscles,
all
too.
that stuff, yeah, but you saw me start, that's exactly what it was about.
Yeah.
And it's also related to assessment. I need to confirm there's no hard joint end feel, that there's no nerve impingement. So a couple of quick things. A little bit of pressure straight down onto the sacrum. Confirming that that doesn't elicit a nerve signal.
Okay.
Big time win. Like as long as there's no nerve zap, that's okay. No nerve zap, no hard end feel. No nerve zap. No hard end feel. No hard end feel. No hard end feel. But limited range of motion. My contact needs to be on the pelvis in order to confirm what the actual end range of the hip is. I need to know when does the hip stop moving at just the hip joint. If I don't confirm that, then I could pull and a person's pelvis will make up the difference. So you have to always be stabilizing, even at like the knee joint, where we're doing like really specific joint assessment, stabilize the structure above it, and then move so that you're moving only and assessing only the joint in question. A shortcut here for the hips / pelvis is that if I just apply a little bit of pressure on gluteus maximus, I just start massaging, but not a lot of pressure, just enough pressure to stabilize the pelvis. Now I can incorporate this motion. I can see, plenty of external rotation. Don't let the foot trick you. It's what the femur is doing, okay? So don't pay attention to the lower leg. To think about what the femur is doing. External rotation versus internal rotation. That's a discrepancy. This mimics what most low back dysfunction will look like. They feel pain in the low back, but when you check their hips, they'll have lots of external rotation and they'll be limited in internal. Very common.
So
Now,
is that limited?
this is limited, yep, it should be 45. Ideally more like 45. 45 and 45. So, now gluteus maximus isn't involved with rotation too much. It has a little bit of abduction, like they all kind of smear together some, but gluteus maximus is more about hip extension and hyperextension. So here, incorporating a little bit of rocking. Now I'm going to get onto, I'm trying to get, to be on gluteus maximus itself, that's more posterior, of course. Making sure that's good, but I don't feel anything like the muscle is overly tight related to the low back. And her symptoms also were on one side more than the other. If somebody says that their low back pain is more on one side than the other, tends to be more lateral. The issues tend to be more lateral rather than posterior. If they say it's the same on both sides, then it tends to be more like an erector spinae or psoas related thing. So, gluteus maximus, that's the one I took off of here. That's deltoid. Gluteus maximus. They're paired. They look a lot alike. All right. And that's a thing to remember. Shoulder, hip, pelvis, scapula, femur, humerus, radius, ulna, tibia, fibula. They're very similar in how they're designed. More structure, more mobility. But even the muscles in their designs are very similar. All right, gluteus maximus. More about hip extension. Gluteus medius and gluteus minimus. Now look, gluteus medius has a good section of it that's relatively posterior. You can get to it in prone. It's not perfect, but you can. You just have to get a little bit lower and increase your elbow angle So I go from here to here. Now gluteus medius and minimus are involved with hip abduction as well as internal hip rotation. So they're involved with hip rotation, is the important thing. When I started here, I just bring my elbow more to the lateral side of the body and then increase my elbow angle. And if I try anything a little bit in order to get on these more, I'm actually going to apply pressure in such a way where I hope to push her pelvis into rotation so that I'm more and more lateral. So that's part of what this shaking, this oscillation is doing, is I'm actually trying to lift and push so I'm more on medius. See how I rolled the pelvis? Did I agree more on that? Yeah. Okay. Now I want to make sure. These can be quite sensitive. So is pressure okay?
Yep.
Okay. Is it enough? Would you like a little more? Is that good?
Try a touch more.
Touch more. Okay. Now, I'm here. Incorporate only the amount of movement that's okay for you. Here. Now I could certainly have the client do this action. Could say, you know, feel how I'm moving your leg this way and that way. Can you do that real slow? I'm just going to give you a little resistance. So you just push through me. Go the other way. Keep going. Keep going a little further. Keep going one direction. There you go. There you go. Keep going. Keep going. Keep going. Then switch. Go the other way. So a little bit of resistance through range, not end range, but through some range. Switch. Push through me. Keep going. Keep going. Keep going. Okay. Switch. And good. Slowly relax. Rhythmic. Rhythmic. All right.
The kinetic change, that felt weird. Like when you first started moving my leg back and forth, I could feel it in my other knee.
Intriguing.
Like, I don't know, weird sensation.
Felt it in the other knee. So listen, when a person is body aware enough to even give you that assessment, not everybody can, pay attention to that, because that might cue you in on an area that's involved they may not have previously thought was symptomatic. It may not be symptomatic, but it might be involved in the adaptation pattern. Now we're going to the deep lateral hip rotators. So we talked about those. All we have to identify, the greater trochanter, and then go just lateral, just medial, sorry, medial posterior. Greater trochanter and go medial posterior. And they cover more space than you realize. I'm sorry, I keep on going back and forth. They cover more distance than you realize. I'm going to move the hamstrings out of the way. Look how high up piriformis is, and then all the way down here, that's quadratus femoris. It's quite a bit of distance, right? So now we get to be more thorough. I start you off with just an application on kind of all of them, but now we can get more targeted, where I start naturally more superior on piriformis, and then I'll work more inferior. I tend to not worry about the small ones. The small ones are called, all of them are called piriformis, obturator internus, obturator externus, gemellus or gemellus, inferior, gemellus superior, and then quadratus femoris. That's
Would this be easier to get in sideline?
no is the issue. You can work on them, don't get me wrong, but you would have a difficult time incorporating as much of the joint movement.
Yeah.
And since they are more posterior, you can get a bit better leverage here. Now you can get them in sideline, we'll look at that a bit, but you're just a little bit more limited in the height of the upper portion of the leg. So, but do you think of that as a consideration? Because it's better than nothing. I prefer this, but there's nothing saying that working on them in side lying isn't also very beneficial. I just like being able to get this additional range of motion, plus getting a bit more pressure. So the lateral hip rotators, guess what action they do? Lateral hip rotation. So if I want to shorten them, I take them this way. But if I want to lengthen them, this way. And the assessment we found was there was too much external rotation, not enough internal rotation, or too much lateral rotation, not enough medial rotation. So what I'm doing is applying compression and then pulling those muscles long. We could call that a pin and stretch. Anywhere in the hip joint. What's also really nice about this is when you do this motion, it rolls the greater trochanter out of your way. So I actually feel like it creates more space for you. So compression, and then bringing the leg into internal rotation. Now I've done a pin and stretch. Compression plus lengthening. And then I work my way lower. But in order to get lower, I do have to kind of change my angle. I'll start here, and I'll end up here. Let me get the middle one. And then the lower one. Quadratus femoris, I personally believe doesn't get worked on enough. People think a bit too much about piriformis. Don't get me wrong, it is the biggest one. It is the more common one related to sciatic nerve impingement. But I tend to think that if the symptoms tend to occur, especially related to long-term sitting, quadratus femoris is often at least a big part of the issue. All right, and more shaking.
That's so weird. I can feel it all down my right leg.
In not a bad way.
No, it's like this, just a sensation.
Intriguing. I would like to think that's because we've increased some kind of neurologic circulation. There we go. So other versions of shaking, you can't just grab. Show them that. All right. Now in this position, we've seen working on the leg enough. If for an adaptation, we've looked at this some, and it's not my favorite, but an adaptation for working more on the medial sides of the leg. Because here's the issue, is that the hamstrings is where your repeated hearing of this hopefully sinks in. Remembering that the hamstrings split at the knee, are very uniformly posterior, but then they come together and attach very medial up onto the ischium. Right? So that means that they're running from here over. So the only way to get to the proximal hamstrings is to work more medially. And that's hard to do in this position. I would have to reach and end up using my elbow, and it's going to be pretty ouchy. So, if I get myself set up here on the other side of the table, then I have to be cut. This is where I use a soft fist. Not an open palm, a soft fist. I don't go too high, but then I could work here. And that gets the proximal hamstrings. If I were to go lower, or even more medial, then you could work on some of the adductors in this position too. But if you have access to side lying, I don't understand why you would want to do that. But if somebody couldn't lay in side lying, then this is an option. Soft fist is really the thing to do for this proximal portion, just because you're pretty close on the medial upper part of the pelvis, like pretty close to the medial portion of the pelvis, right? It's a real good euphemistic way of saying it. But lower by the knee could use a palm. And I can pull the leg right to me. So if I even kind of like lift the leg toward me, bring the legs closer together, application right near the knee. Many of the adductors are this low, and the hamstrings certainly are. So this works pretty good. The only caution a little bit is if the knee has issues, because I am kind of torquing at the knee a little bit. But it works okay. And the same thing could be said for the medial half of gastrocnemius and all those structures underneath of gastroc. So gastrocnemius, soleus, but then all those other muscles, tibialis posterior, flexor digitorum longus, flexor hallucis longus. This is a way that I could at least affect those. If I can reach enough to make full contact, I can reach all the way over to tibialis anterior. I can get that anterior compartment. That's tibialis anterior and extensor digitorum longus and extensor hallucis longus. The fibularis group on the fibulus, so also called the peroneal muscles, and over here. So it's a kneading action. You know, please use sideline with most of your clients, but you have the person that can't. There we go. And it is a way to change up how you use your body. So I did used to do this with the athletes. It was, are you kind of shorter and are you kind of lanky? And I would actually switch and do this with them, because the really big guys, I would have in sideline and I'd be using my body in a different way. So it was a way for me to change up my body mechanics. And right there, although it's kind of more general, it's not targeted at any one of those compartments. It's not targeting any individual muscle, but it's affecting basically everything, all at once. So if I had to just do a quick lower leg massage, because I was going to spend more time on the neck and shoulders, then this would be the way to just do that and be done with working on the legs. I still would have to get the anterior upper leg. The foot in this position, not my favorite at all. I just gotta find the bolster. Remember to try to get the top of their foot touching the bolster. That will save you a lot of effort. You said some issues with this. Is it more in the ankle or the foot?
It's the butt, like, right under where my heel would be,
Say that again.
right under where my heel is, kind of.
Okay, yep.
Yeah, like up in there.
A true plantar fasciitis. Wow. Might not actually be that, but that's a common, that's the attachment site, is on the calcaneus. We'll have more of an anatomy time with that, but you know, big bone here, calcaneus. On top of that is talus. Talus is what touches your tibia and fibula to actually make the ankle joint. The talus is the one actually making up the ankle joint, and then your biggest one is what it's sitting on top of. Think of it like a person riding a horse. Talus is the rider, but it's holding the leg up, and calcaneus is the horse underneath, and that's where you're actually making the strike. So with that known, sometimes I don't want the person, I don't want talus getting squashed into the horse, into calcaneus. They need to know that they're their own separate beings, right? But if the person's been pancaked onto the horse, it's a bad time for both. So in this orientation, I don't worry about talus, I think about calcaneus. If I can just grab the heel, what people call the heel, when I'm really grabbing, now you have a nice like extra fatty layer on the bottoms of our feet. And I feel like the squeezing of the heel just feels fantastic, by the way. But I want to feel like I'm lifting the tissue at the heel up and away. But while I'm doing this, I mean, I am putting pressure on calcaneus. So if I can move the other bones underneath, here's calcaneus and here's all the other bones. Maybe I can create some mobility there. So squeeze, I go over onto the first metatarsal, which becomes the big toe. First metatarsal, and then it's back and forth. It's still a push and pull. Now that tends to take the arch of the foot and exaggerates the arch. I come around to the other side and do the exact same action but reaching across. And it's just in prone, my best shortcut for the feet. Working on the rest of the foot, you gotta get yourself on angles. If you're stuck working on the foot in this orientation, just don't stand here. You gotta stand at an angle. And sometimes you're reaching. If you can, maybe, get up on the table or something like that. It's not perfect, but stand on an angle. This is where the biomechanics are really terrible for the feet in this position. Soft fist, I can do okay, like this, right here. And for this specific spot, I bet that working through here, that should feel good.
Yeah.
So, where you have to go downhill. Don't put too much lotion, make contact, sink in, and let everything pull you downhill. For a forearm, we can do this. This is one where I just end up having to,
Table.
I just put my elbows on the table to start. This arm is on the table to help hold me up. This is where I really just do. But you gotta you're not doing this. You gotta let this arm hold you up. Then, this is what I actually do in this position. It just looks like terrible body mechanics, because it kind of is. I mean, I got my belly right on the table. If a person's taller, then I'm not gonna have to reach, right? This works pretty good, as long as it doesn't hurt you, but the big trick is, here, let this hold you up. I hold their foot and support their toes, so that if I do that, then their toes are just gonna get bashed into the table. So, hold their foot, rest your arm on the table. And this works really good, it's not the best initial body mechanics one. I still would always prefer to do it in sideline. But this will work for a little bit if I need to. Key area to avoid is what's called the ball of the foot. It's just where the first phalange, your big toe, ends and the metatarsal starts. There's two little extra bones there. Don't push there, but the other areas are fair game. So I'll put my hand under the 4 small toes, the 2nd to the 5th digit, but I'm just lateral to the big toe, to the first metatarsal. I don't want to push there, but over here, as much as you want. But you gotta just be confident that you're avoiding hitting what people call the ball of the foot, just like we'll say the heel. But that's not what you would use in medical terminology. All right, more real time here. Let's go here. Rocking. Okay, I'm going to assess the hip, but let me do my oscillation. But see, that's one thing a bit. If you want a more honest assessment, you don't want to start intervening. So I can be guilty of already doing stuff like that, but frankly, by the time I go to the more specific assessment, I might have already changed something. But you're good.
And for a
It's
moment there-
zoomed in, so
Yeah.
no worries. I'm getting better at editing, so. Bit by bit. So, lighter pressure, but my goal is just to stabilize the pelvis. Now we're checking. That's less than the other side. way more. And I just gotta process that. So in this case, it's like, that's not about the deep lateral hip rotators. If the symptoms are over here and that leg is able to go into this kind of rotation pattern, that means it's not about the sciatic nerve. It's gotta be something else. It's gonna be about frontal plane movement, which we had already kind of distinguished. So that would mean it's gotta be more about like side lying and all that. What time, by the way, is it? I know I'm running.
11:52.
All right. Twins. How are we doing there? Okay. So for the glutes, I tend to move the leg into external rotation. It just kind of works better body mechanics wise, but it's also a way to encourage the hip mobility in that direction. We want both, right? So this is an encouragement into external rotation. And I'll use that for gluteus maximus as well as gluteus medius. Then coming down, I'll get on the deep lateral hip rotators, and this is just my preferred tactic, is I'll start, pretty much at neutral position, maybe a little bit in external rotation, but predominantly the movement is going to be encouraging it into internal rotation. Still, for me, it's hard to keep, as I verbalize that, it's straight because of where the foot is oriented. So that's internal rotation. But because of the mobility being so good here, I know immediately that these muscles are not the problem. So I'm not going to waste my time here. I'm happy I was thorough over there. And maybe that's why she was getting all those signals of sensation. Maybe neurologically, there is something freeing up down to this right leg by freeing up stuff in the left hip. And that's where you just can't make a lot of assumptions. And frankly, where going to the side that's asymptomatic, working there first, and then coming over to the symptomatic side, that's just gonna always be your best blueprint for success. And never just doing spot work, Oscillation for days. Oscillation for days. This is where you do get a little bit of a workout. There's no way around it. You just do it. That was a really good.
Thanks, Mom. Feels great.
That was an amazing catch. Oh, but no happy sack.
I know, right? It's been a minute since I've had to do that.
So here, to get the lateral sides of the legs and everything, like this works okay. So I didn't do it on the other side, but just kind of as a refresher. If I'm thinking about how to work on the legs and I'm limited to prone, then when I'm standing on this side of the table, I'm worried about only the lateral half of the leg here. And not gonna worry about going high up in the hamstrings because they go more medial. So I just worry about this more lateral side, and I stay more distal. Incorporate a little bit of joint movement. Come down, doing a shortcut, come around. See how I roll the legs so I'm always more lateral? And then I can sneak around. Bend the leg again. Make sure I have it. Now we can work more proximal. Now here I feel something, and that's the asymmetry. Comparing the proximal hamstrings on this side to the other side, there's something more just vaguely going on. The tone is just a little bit increased. So tighter. Yes. Yep. Tighter. How would I say that in Spanish? Be más something. See, you don't do an ER at the end. That was something I learned. There's no ERs at the end for
Or whatever.
comparison. It's always must or may know something, right?
More tension?
More
Yeah,
ten-
probably
más
go with
tensión?
this, yeah.
Oh, cool. That's easy. Más
Big
tensión.
one. That was easy.
Yeah.
I-O-N. Sion.
There it is.
All right, so palms, now that I'm working my way closer to the knee. If you're real sneaky, you can't see it very well. Let me show it here. You can go so far as gliding across the hamstrings, going to the IT band, and then pulling. But the leverage is difficult. That kind of reach, if you have any kind of low back issues, do not do that. Because once you go this far, I'm going to be naturally leveraging a little bit of my low back. So don't do that. Just do, so,
Do as you're told, not
yeah,
as I.
yeah, not as I show. Do what I say, not what I do. Here, same thing. The problem in this orientation is the reaching. So a slightly lower table or using the step. With a hydraulic table, you have no excuse. But that being said, chronically I would forget or just not bother to move the table. But when you get access to that hydraulic table, please just find that pedal and use it, because it can save you a lot of little effort. There. And here, grab that heel. Same action of a push and pull. And I'm kind of thinking about the fifth metatarsal versus the first metatarsal. The fifth and fourth metatarsals are unique in how they come together meeting cuboid, one of the tarsal bones. There's much more structure on the lateral side of the foot, much more mobility on the medial side of the foot. Thus why there's an arch. So this half versus this half. So with that, I'm thinking, basically, am I moving the metatarsal of the pinky toe? And this, I'm thinking about moving the metatarsal of the big toe. And that inadvertently we'll do a lot of stuff related to the metatarsals and where they meet the tarsals. It's a cool thing, because I'm holding calcaneus down, the largest tarsal, and I'm moving the metatarsals. And I can make it feel good. Let me come around. Bolster the hand, elbow on table. I need more lotion. I start right below, at least in this orientation, I can think of it as below, the calcaneus. So I'm trying to be on the attachment of the plantar fascia. It's not perfect, but I let my arm track towards the arch of the foot, medial, and then come down. I end up feeling like I'm doing this, going at an angle towards the arch. And here even, because I'm at the point where I can find the ball of the foot, the ends of that metatarsal, and use my forearm and elbow instead of using the soft fist.